Hello, my name is Dr. William Barnes, and I'm a general surgeon, and I trained at the Cook County Hospital in Chicago back in the 70s and 80s. Today, acid reflux is very, very common. There are probably 60 million people in the United States that have some form of acid reflux. There are 30 million prescriptions for a PPI that are written every year in the United States. And the PPIs nowadays, everyone has heard how bad they are. They affect the ability to absorb calcium and minerals, and they affect the immune system. The PPI stands for proton pump inhibitor. It inhibits the stomach proton cells, the cells to pump the proton out, which is hydrogen, to combine with the chloride that makes the acid that affects the reflux. So it stops that, but it also stops the proton pump in all of your cells. And the endothelial cells, which line all your blood vessels and all your organs, that proton pump pumps the garbage out of the cell. So now you're not pumping the garbage out of the cell, and you're living in a garbage dump taking that medicine. And those cells die early, and it has a lot of reason we think may be causing the Alzheimer's disease, heart disease, and the kidney disease. So, and you can't really get off of that medicine if you have acid reflux. That PPI stops the acid from refluxing, so it stops the heartburn. It does not stop the reflux. You still reflux bile, pepsin, and so forth. So back in the 50s, surgeons, Dr. Nissen, for example, designed this operation. Went through several different types of operations to repair this. And that operation was a big operation. We'd make a long incision. We'd reach up into underneath your heart, grab that esophagus, go around it with our hands, pull it down, sew up the diaphragm, and then divide these vessels along the outside and wrap this stomach around the esophagus and sew it up, and that recreates the natural barrier that God prepared for us. And it really, really works. Of course, you can see it's a huge operation. And in the 1990s, technology advanced. We started doing laparoscopic surgery. We found we could do this operation laparoscopically. It's still a relatively big operation. You have to have a big hole for the camera. You have to put a report in to lift the liver, several other operative ports, and so there's several stab wounds. And then we get down up underneath the liver and we dissect around and we make this new valve, pull the esophagus down, close up the diaphragm, wrap this stomach around the outside of it, sew it up. After we've dissected these valves, there's still some danger involved in it. And so this really works, but the problem with this and the other operation is that both of these are so good. It's a 360-degree wrap, totally wrapped around there, and it stops the reflux. But one of the problems is that you cannot belch and you cannot vomit after you've had this done. And people that have this problem, the esophagus is irritated for so long that they do a lot of air swallowing. In order to get the debris off the distal esophagus, they swallow air, they belch, and half of the air goes up, the other half goes south. However, once you've done this wrap, 100% of the air goes south. And I tell all my patients that because they cannot belch and they cannot vomit, they are very uncomfortable. If you get 100 of them in a room and you ask them how they're doing, 70% of them will say, I'm not doing good. Why is that? Well, I'm very uncomfortable. I'm bloated all the time. My stomach is rolling all the time. I have uncontrollable gas. I pass gas and I'm afraid to go out. I can't go to dinner. I can't go to a ball game. I can't go to church because I may frequently pass a large, loud amount of gas in public. And so I'm restricted from going anywhere. I stay at home most of the time. If you ask these patients if they'd have that operation again, 70% of them say, if I knew then what I knew now, I would not have that operation. And so there's the drawback of that. So now technology has advanced, and this endoscopic device was developed where we can now repair that valve with this device. And it's an endoscopic procedure. We avoid all that discomfort and all the trauma of that surgery. Endoscopically place it into the stomach, and camera comes out and looks back at what's happening here. We have a device that grabs this esophagogastric fundoplication, pulls it down into the device folds the stomach up, and we fire these sutures in a sequence endoscopically, and when we get done, the valve looks exactly like the fundoplication that's done with the Nissen from the inside. it functions exactly like the fundoplication done with the Nissen from the inside, and you can't hardly tell the difference. However, when you measure the pressure, it's exactly the same. It stops the reflux. The difference is it is not 360-degree rep. It's about a 270 to a 300-degree rep. And so these patients, they can belch and they can vomit if they need to. One of the other advantages of this operation is that if another surgeon does this surgery with this device, his results are going to be exactly the same as my results. The Nissen, however, if one person does that and another person does that, the results may be a little variable because there is some art to that. But this is a tool, so that the results are consistent along the board. And these patients, if you get them together 3 years later and you ask them how they're doing, nearly all of them say, I'm doing great off of the PPI, I'm doing well. Would you have this operation again? Nearly 100% of these patients say, you bet, if I had to, I'd have it done again, because it's not that invasive compared to the other operations. It's extremely effective. Most of my patients are happy patients, which is really gratifying for a general surgeon, because they come back, either they're happy or they're very happy, or it's a life-changing operation. So I think in the future this is going to be the operation of choice for acid reflux.